I'd like to welcome everybody to this webinar. We will start going in just a moment as soon as I share my screen. Okay, so today we're going to talk about the current diagnosis and management of the adult growth hormone deficiency syndrome. I have been a consultant for many of the companies that make growth hormone. I've listed them here. The goals for this lecture are to review the causes and the clinical features of adult growth hormone deficiency. I'd like to tell you a little bit about the differences between childhood onset and adult onset growth hormone deficiency. And we'll talk about some special issues, including traumatic brain injury and transition patients, those who are transitioning from pediatric to adult care. I'll review the evidence for the efficacy of growth hormone replacement therapy and discuss the current ways that we make the diagnosis. And then finally, I'll get into some special issues concerning the clinical use of growth hormone for adult growth hormone deficiency. Much of what I'm going to tell you has been recently published in the American Association for Clinical Endocrinology recent guidelines for patients with growth hormone deficiency. It was just published last fall in Endocrine Practice, and I would refer you, it's a very extensive review. Well, in the past, growth hormone therapy was a very difficult enterprise. Beginning in the 1950s, human growth hormone was purified from frozen pituitary glands that were obtained at autopsy from patients who were generally healthy prior to death. But as you can see, these were sent in by pathologists, and they would be batched, and each preparation that was purified would have between 500 and 20,000 glands. These would be frozen, added to dry ice, and then pulverized, as you can see here, this modern extraction method that was shown back then. Small amounts of growth hormone were available for research, and it was only available for intermittent treatment of really the most severely deficient growth hormone children. The early preparation contained many growth hormone polymers, and it was contaminated with other proteins. By the late 1970s, the purification method was greatly improved, and the quality of growth hormone was now quite good. And over about 35 years, more than 30,000 people received this cadaveric growth hormone. However, in 1985, the first cases of contamination by a prion causing Creutzfeldt-Jakob disease were reported. In fact, we saw the first one here at Stanford. And more than 200 patients have been affected to date. And of course, this is a rapidly lethal, tragic neurologic disease. And in 1985, cadaveric growth hormone was withdrawn from the market in the United States and in most of the rest of the world. Fortunately, at around the same time, Genentech was making a synthetic human recombinant growth hormone. And they put that on the market 6 months after cadaveric growth hormone was removed. And soon many other companies also began to make growth hormone. And we now had unlimited amounts of growth hormone available for both experimentation and clinical use. This allowed us to give growth hormone as a daily therapy, whereas in the past we often had to use it every other day in children. And I think more importantly, it led to the discovery of a new disease, the adult growth hormone deficiency syndrome. We'd never really talked about growth hormone deficiency in adults, probably because we never had a way to treat it and to really determine whether it was a true syndrome. And in the late 1980s, this was clearly characterized both childhood onset and adult onset growth hormone deficiency. So what are the clinical features of the adult growth hormone deficiency syndrome? One of the major ones is an alteration in body composition with increased abdominal and visceral adiposity, decreased lean body mass, reduced functional capacity, and social isolation. These patients were at risk for cardiovascular disease and for fractures and for general um, low quality of life. Moreover, by the late 1980s, we learned that patients who were panhypopituitary and had been replaced with adrenal, thyroid, and gonadal hormone replacement therapy still had an increase in mortality. And in fact, if you look at cardiovascular mortality, it was more than doubled. Over the next 35 years, there have been about 6 studies that are meta-analyses looking at over 20,000 hypopituitary patients and 100,000 patient person years. And this confirmed that hypopituitarism was associated with an excess mortality, even if replacement with adrenal, thyroid, and gonadal hormones had been achieved. Women had an even higher mortality than men. There has been some suggestion, however, that once we started using growth hormone replacement therapy, that this mortality risk returned to normal. Well, the causes of adult growth hormone deficiency are many, but primarily they are tumors of the pituitary or hypothalamus. And these are usually pituitary adenomas, craniopharyngiomas, meningiomas or Rathke's pouch cysts, and germanomas. Individuals, primarily children with leukemia who've had cranial radiation, are also at risk of developing growth hormone deficiency. And patients who get autoimmune hypophysitis are being more commonly seen. Less commonly seen are patients who have infiltrated or infectious diseases such as tuberculosis or sarcoidosis. Another major cause that we'll get into in a minute has to do with traumatic or vascular injury to the pituitary, including traumatic brain injury and subarachnoid hemorrhages. And finally, there's the whole category of adults who had childhood onset growth hormone deficiency, either as an idiopathic isolated growth hormone deficiency, as part of some genetic syndrome, or because they also had pituitary or brain tumors. If we look at the etiology of childhood onset growth hormone deficiency, we see that about 3/4 of these children have what has been called idiopathic growth hormone deficiency. And usually it's isolated, and we often, of course, don't know why they have it. Only about 1/4 of the children actually have organic causes, including trauma, craniopharyngioma, radiation, and tumors. Another population that we have to take into account is survivors of childhood cancer. And this is becoming a growing population. This is a slide showing people who've gotten radiation therapy that includes the pituitary gland. And as you can see, within a couple of years, a majority of these individuals become growth hormone deficient. And if we follow them out for longer periods of time, we see other pituitary hormone deficiencies that also occur. So as adult endocrinologists, we have to be cognizant of individuals that were they may have delayed or premature puberty and have hypogonadism from primary gonadal dysfunction. Moreover, many of them will also have bone disease and be at risk for osteoporosis. So as adult endocrinologists, we are now seeing a whole new group of patients who have fortunately survived their childhood cancer, but are now suffering some of the sequelae of the therapies that were used. Now, there are some differences between adults with growth hormone deficiency who acquired their growth hormone deficiency as children or as adults. So in comparison to the adult onset patients, childhood onset adult growth hormone deficient patients tend to have much more reduced bone mineral density and bone mass. Maybe they've never really accumulated enough mass in the beginning. They have more reduced muscle mass, and they tend to have lower IGF-1 levels. On the other hand, they tend not to be as heavy. They have lower BMIs and reduced waist to hip ratios compared to adult onset patients. They tend to have less visceral abdominal fat. That's probably because they haven't had a time to accumulate it. Their HDL cholesterols tend not to be low. And in general, they have better quality of life scores than those people who acquired their growth hormone deficiency as adults. Now, one of the things that we recently recognized is that traumatic brain injury may lead to growth hormone deficiency, and in fact, it may lead to other pituitary deficiencies. And what are the most common causes of traumatic brain injury? Sports-related concussion has reared its ugly head. And I know here at Stanford, we are doing a lot of studies about concussions and trying to find ways to make sports safer. This has primarily been emphasized in football, where people are constantly butting their heads or knocking heads and suffering numerous concussions. But in fact, worldwide, and probably now in the United States, there are far more concussions that occur in soccer, as soccer players, even young children, like to perform headers that can cause concussions. The question is, will these concussions lead to a mild traumatic brain injury and hypopituitarism and growth hormone deficiency in particular? If we look at football players, we see that they actually have a tremendous amount of problems with this. So this was an interesting study that looked at some retired National Football League players. They looked at 68 men. Of course, all of them have had concussions. And depending on how they made the diagnosis of growth hormone deficiency, between 20 and 40% of these men were growth hormone deficient. Many of them also had other problems, including hypogonadism, and it really affected almost all football players. It didn't really matter what position they played. Of course, most football players get their concussions during practice and not during games. More straightforward traumatic brain injury, things from automobile accidents, from where there's loss of consciousness, boxers who achieve loss of consciousness, and from the military, does also lead to hypopituitarism. We also see hypopituitarism after subarachnoid hemorrhages. And in this slide here, you can see that about half of all patients who suffer these illnesses will have some form of hypopituitarism, either partial growth hormone deficiency or others. Some of these are transient and some of them are long-lasting. Let's move on now to talk a little bit about the transition for the growth hormone deficient patient. The transition refers to the purposeful, planned movement of adolescents and young adults who have chronic medical conditions from the pediatric to the adult-oriented healthcare system. This can be a very traumatic thing for children who are used to a very different atmosphere in pediatric clinics. These problems that I'm referring to encompass a wide range of physical and psychosocial changes at the end of development. And really, this transition begins in late puberty, in the late teens, and doesn't end until we have complete adult maturation in the mid to late 20s. So the transition is not a short period. It can actually be a period of about 7 years between final transition between pediatrics and adults. And the goals of our management for patients with pituitary disease is to reassess the presence and etiology of growth hormone deficiency. If need be, we need to change the dose of growth hormone therapy. We want to maintain surveillance of these patients until they achieve mature body composition, including muscle and bone mass, and sexual and reproductive maturation. We also have to be cognizant of changes in their psychosocial development. And it's very important that both the pediatrician and the adult doctor educate the patient concerning their lifelong health needs, especially in regard to these endocrine requirements. So as we all know, the adolescent brain is still developing. As you can see here, the lighter colored parts of the brain are still under development. And even until we get into our 20s, there are still parts of the brain that are developing. Adults with childhood onset growth hormone deficiency have some impairment in this development. It's been shown that they have impaired memory speed and cognitive functioning, and that this can improve with growth hormone replacement therapy. Functional MRI studies showed activations during working memory tasks in a variety of parts of the brain, including the cortices, the right thalamus, and the anterior cingulate cortex. Growth hormone therapy led to normalization of some of these changes, indicating a more efficient recruitment of neural systems. So that we know that people who are growth hormone deficient can still benefit, even neurologically, at a later age, even after they've stopped growing. Even though we achieve our adult height in our early to mid-teens, we don't achieve peak bone mass until we're in our mid to late 20s. As you can see here, puberty is a time when bone mass is changing quite a bit, but by our late 20s, we've finally achieved peak bone mass. And after that, it's all downhill. We all lose bone mass in our 30s and thereafter. So it's very important for us to achieve as much bone mass as we can in our teens and 20s to prevent osteoporosis decades later. And as I'll show you later, growth hormone is very important for achieving this peak bone mass. If we look at adolescents with childhood onset growth hormone deficiency, and those who are no longer growth hormone deficient have normal muscle strength, but those who are still growth hormone deficient have markedly decreased muscle strength. Well, when we take patients with growth hormone deficiency, what do we expect to happen when we treat them? Neurologically, we hope to improve their quality of life, their psychosocial well-being, and their cognitive function. In regard to the cardiovascular system, we hope to improve left ventricular function, endothelial function, improve their lipid profile, and also their aerobic capacity. Growth hormone should increase skeletal muscle protein synthesis, and with that, increase strength. And with an increased sense of well-being, they may exercise more as well. Growth hormone is extremely lipolytic, and we expect that adipose tissue, especially visceral adipose tissue, will decrease. And we expect to have an increase in bone mineral density. These are our expectations. Let me show you the data underlying them. The other question, of course, is whether there's a decrease in mortality, and we can get into that too. So when we start a patient on growth hormone, we begin to activate bone turnover. Now, when you start bone turnover in the first 6 months, you recruit a lot of osteoclasts to the bone, and that will cause actually a slight decrease in bone mineral density from month 6 to 12 of therapy. But by month 18 and thereafter, growth hormone has a very salutary effect on bone mineral density, increasing it in both the lumbar spine and in the femoral neck. And these are long-term data showing you that even after 15 years of growth hormone therapy, one sees a persistence or an improvement in bone mineral density, especially in men. In women, it tends not to be as pronounced, but it is still greater than in women who are not being treated. So growth hormone will improve bone mineral density, even in patients who have been receiving it as adults for decades. Well, bone mineral density increases are all well and good. The question is, does it make a difference in fracture? And we are now developing data to indicate that, in fact, this is true. So if we compare patients with growth hormone deficiency who received growth hormone to those who did not receive growth hormone, we can see that there is a rather pronounced decrease in fracture risk of all types of fracture, both vertebral and non-vertebral. So that continuing to treat growth hormone deficiency in childhood onset patients or in adult onset growth hormone deficiency can improve bone mineral density and decrease the risk of fracture. There have been numerous meta-analyses looking at the cardiac effects of growth hormone in adult growth hormone deficiency. And almost all of them will show an improvement in left ventricular mass and an improvement in left ventricular diastolic diameter and stroke volume. One of the most consistent changes when we start giving growth hormone therapy to patients is a decrease in fat mass. It's not a dramatic improvement. In general, patients will lose between 2 to 5 kilograms in fat mass. Much of this fat mass, however, is visceral fat, not the subcutaneous fat, so the patients may not recognize it as much. But the decrease in visceral fat can be quite pronounced, and in theory, decreasing visceral fat would improve cardiovascular risk. We suspect that giving growth hormone therapy will increase patients' exercise. And we think it does this by making them generally feel better and feel like stronger. There haven't been very many studies, but this one here that was published a decade ago looked at patients before and after they received growth hormone therapy. And I think you can see that the total amount of activity increased quite dramatically after growth hormone. I like to measure this in my patients by asking them to look at their cell phones and determine how many steps they've been taking over the last couple months. And then when I see them again in 6 months, I like to compare the difference. And I think that in many cases, we see a dramatic improvement in activity. A number of quality of life questionnaires have been developed for many diseases, and there have been some that have been very specifically developed for hypopituitarism and for growth hormone deficiency. And these have been used frequently in studies, I think less frequently in the clinic. And I personally do not use them, but they have been of use in demonstrating the quality of life does improve. So this is a study that looked at healthcare consumption before and after 1 year of growth hormone. Days of sick leave over the previous half year. In the subsequent half year, after they've been on growth hormone for 1 full year, you can see that the number of sick leave days has dramatically decreased from about 9.5 to just under 4. Similarly, the number of days in hospital have also decreased from 1.7 over the previous 6 months in the patients prior to getting growth hormone to less than 1 in patients on growth hormone therapy. Similarly, doctor visits have also decreased. So healthcare consumption decreases, and that suggests that patients are healthier and have a better quality of life. And then finally, as you can see, leisure time activity also increases. By looking at some of these questionnaires, people have shown that there is a long-term improvement in these quality of life scores. And these studies here looking at both men and women showing an improvement in quality of life that is really quite durable, lasting in this study for 10 years. My favorite study on quality of life, however, was in a double-blind, placebo-controlled trial that was reported a number of years ago, where patients received either a placebo or growth hormone, and then they were given questionnaires to try to determine if their quality of life had improved. And when they answered those questionnaires, there was a modest improvement in some aspects of quality of life. But what these investigators did was to ask their live-in partners or spouses how they assessed the patient. And as you can see, the partners and spouses were very, very, actually very excited and showed and claimed that there were really dramatic improvements in the patient who was getting growth hormone. They were more alert and active, less worried, more extroverted, even better looking, and that their personal relationships were better. So that I think sometimes the patient who's getting growth hormone, and as we'll see, we have to understand that growth hormone therapy leads to rather gradual effects. It's not an overnight improvement, that the patient may not really recognize how much better they're getting, but that their partners certainly did. Okay, now we have to get into how do we make the diagnosis of growth hormone deficiency. Growth hormone, as you know, is secreted in pulses, and in adults it's mostly at night, so that if we were just to get a single growth hormone level at any given time, it would likely be extremely low, and we can't make the diagnosis that way. Instead, in most cases, we have to do a growth hormone stimulation test. And we do this by using a variety of pharmacologic agents which provoke the release of growth hormone into the bloodstream. And then we measure growth hormone several times after the agent is being given. And over the past 30 years, many pharmacologic agents have been given, but we've learned that many of them really are not effective. So we no longer believe that L-DOPA, clonidine, arginine, or predostigmine stimulation tests are of any value in making the diagnosis of growth hormone deficiency. We used to use a combination of growth hormone releasing hormone plus arginine. This is a very effective way of making the diagnosis. Unfortunately, growth hormone releasing hormone is no longer available in the United States, so we cannot use this as a test. And we are left with two tests that are available. The so-called gold standard test, the insulin tolerance test, where we inject enough insulin to cause hypoglycemia, which then triggers the release of growth hormone, and the glucagon stimulation test, which by unknown mechanisms increases growth hormone. Within the last year, however, we also have an oral stimulus called ghrelin, mimetic, which is named masomorelin. And these are the three tests that are currently available to make the diagnosis of growth hormone deficiency. So let's go over the characteristics of these tests. We say the insulin tolerance test is the gold standard. And in fact, it really does test the entire axis. Unfortunately, it really is a difficult test to perform. You have to have an intravenous in the patient. You have to have a healthcare provider, a nurse or a physician at the bedside as you inject the growth hormone to make sure that you are not making the patient severely hypoglycemic, because you can cause seizures and even death in some cases. It's probably not safe in elderly patients. It's certainly not safe in patients who have had any cerebrovascular disease or a history of a stroke or epilepsy. And many patients simply won't tolerate it. It's available, it's cheap. The insulin is relatively cheap, but you have to have it in a room. So it's something that I think most places no longer do. The glucagon stimulation test is accurate. It's quite safe. Some patients will develop hypoglycemia at around the 4th hour and will get nauseated, but it's not severe hypoglycemia. It's a very prolonged test, and the glucagon is relatively cheap. Masomorelin, this oral preparation, is an accurate test, and it's quite safe, although there are only a couple of publications, and we don't still know how it works in a variety of young patients under the age of 18, or in patients who have had traumatic brain injury, for example. It's a lot faster than the other tests. It's readily available, and up until recently, it's been extremely expensive, and that's been what's holding it back. My understanding is that they're trying to decrease the cost of the masomorelin. So when we give these tests, we measure multiple samples of growth hormone, and we have different cutoff values. For the insulin tolerance test, as long as all the growth hormone levels are less than 5, we say that the patient is growth hormone deficient. For the glucagon stimulation test, we found that there are changes depending on whether the patient is obese or not. So that if the patient is not obese, the growth hormone can go as high as 3 and still have growth hormone deficiency. But for obese patients, the cutoff is 1. And for masomorelin, the cutoff is less than 2.8. Now, it turns out that not all patients require a growth hormone stimulation test. If a patient has 3 hormone deficiencies, essentially if they're hypogonadal, hypoadrenal, and hypothyroid, the chances of them being growth hormone deficient are more than 95%. And in that case, if the serum IGF-1 level is lower than normal, that is less than 2 standard deviations from normal depending on age, then one can make the diagnosis of growth hormone deficiency without a growth hormone stimulation test. But in all other cases, one must do a stimulation test, and one cannot rely on a low IGF-1 level alone to make the diagnosis. Well, what are the criteria for starting growth hormone therapy? We only test patients who have had pituitary or central nervous system disease, a history of childhood onset growth hormone deficiency, traumatic brain injury or brain irradiation, adults are AIDS wasting, which is something we really don't see anymore with the more modern therapies for AIDS, and short bowel syndrome, although it is not used commonly for this indication. The contraindications for growth hormone are active malignancy. This is because there is a worry that growth hormone as a growth factor would cause active tumors to grow. And there is some data suggesting that patients with acromegaly and concomitant tumors tend to have worse disease. But in fact, there is no good data to suggest that growth hormone either causes a cancer or causes a cancer that's there to grow. Nonetheless, there is a black box warning, and active malignancy is a contraindication for growth hormone therapy. Patients with critical illnesses in the ICU should not be given growth hormone. And in fact, we usually stop growth hormone therapy when patients are admitted to hospital. This is because of a study that was done a number of years ago where relatively high doses of growth hormone were given to ICU patients, and they found an increased mortality in that group of patients. We don't give growth hormone to patients with uncontrolled diabetes because it will make it worse, but we do give it to patients who have controlled diabetes. That's not a contraindication itself. Diabetic retinopathy is a relative contraindication to growth hormone therapy. It's very important for everybody to recognize that it is actually illegal to prescribe growth hormone for non-indicated diagnoses. That when growth hormone became available in the late 1980s, a law was passed to prevent its abuse, and that law stated that you could not prescribe growth hormone off-label. This was done to prevent its abuse in sports, and more recently, its abuse in giving it as an anti-aging drug. We'll get into that in just a moment. Well, when we consider growth hormone dosing, we monitor by serum IGF-1 levels, and we try to keep the IGF-1 level within the normal range. Now, if you look at these graphs, you can see that IGF-1 levels peak in adolescence and then decline throughout life. The levels have different normal ranges for both men and women, and the normal ranges depend on the patient's age. So we need to know both the IGF-1 level and the patient's age to determine that our growth hormone therapy is achieving proper IGF-1 levels. We start with a low dose, in general, on the order of 0.15 in middle-aged to older individuals. Sometimes we'll go as high as 0.6 milligrams per day in young women, especially those who are taking oral estrogens. We can then titrate the dose of growth hormone based on their clinical and biochemical responses. In general, we use lower doses for older patients as they're more sensitive to the side effects, and the IGF-1 target level is also lower. In the past, when we started the older patients on high doses, patients complained of pedal edema and carpal tunnel syndrome. The usual maintenance dose for most patients is going to be less than 1 milligram per day. However, we often have to use higher doses for premenopausal women, and for women taking estrogen. What are our expectations? It's very important to warn the patients that the improvement in symptoms may require quite a while, anywhere from 3 to 6 up to 9 months. And it may take up to 3 months or longer to achieve a proper maintenance dose. They should be told that their body composition will improve, but their total body weight probably won't change unless they do a lot of exercise. There will be an improvement in lean body mass of several kilograms and a loss of fat mass that is similar, but it is not a weight loss drug. The side effects sometimes may dictate the final growth hormone dose, and sometimes we can't go as high as we want if the patient experiences pedal edema or carpal tunnel. I follow patients primarily by clinical symptomatology and their serum IGF-1 levels. We measure hemoglobin A1C and lipid levels, their body weight and weight circumference, bone mineral density as appropriate, and I try to quantify their exercise. Again, now that people are wearing Fitbits and cell phones, we're able to do this in a more systematic way. When we give growth hormone, we have to be cognizant that there are many hormone-hormone interactions. The most important one involves the hypothalamic pituitary adrenal axis. Growth hormone increases the conversion of the active hormone cortisol to the inactive metabolite cortisone. Therefore, when we start growth hormone therapy, we are going to increase the turnover and metabolism of cortisol. And deaths from adrenal insufficiency have been reported after starting growth hormone. Therefore, it is crucial to evaluate the hypothalamic pituitary adrenal axis both before and after starting growth hormone. If patients have not been treated with hydrocortisone, it is especially important to make sure that they don't have borderline adrenal insufficiency, because you can tip them over by starting growth hormone. Some patients may require an increase in their hydrocortisone dose if they are currently hypoadrenal. Similarly, growth hormone increases the peripheral conversion of thyroxine to triiodothyronine, T4 to T3, and it may unmask secondary hypothyroidism. So it is important to evaluate the thyroid axis after therapy. And since, of course, we can't use the TSH level in patients with pituitary disease, it's important to keep the free T4 level in the mid to high normal range. Patients who are already on thyroid hormone prior to growth hormone therapy may require a dose adjustment in LT4 replacement. In regard to estrogen replacement therapy, it's been known for many years now that oral, but not transdermal estrogen therapy will blunt the ability of growth hormone to increase serum IGF-1 levels. And therefore, growth hormone therapy is often required to be in higher doses in women taking oral estrogens. There are occasional patients on oral estrogens where even going to doses as high as 2 milligrams a day of growth hormone will not produce a sufficient increase in IGF-1. And in those cases, I recommend that the patient switch to a transdermal estrogen to obtain an optimal IGF-1 level and spare the cost of having to take so much growth hormone. Recombinant growth hormone can be continued during pregnancy until the end of the first trimester in growth hormone deficient patients, because by the end of the first trimester, the placenta begins to make a placental growth hormone, and that will increase the IGF-1 concentrations. And while some endocrinologists do continue growth hormone therapy in the first trimester, it's important to recognize that this is not FDA approved. FDA has not approved the use of growth hormone in pregnancy, and we don't have data to suggest that continuing it in these growth hormone deficient patients really is of benefit. In patients with diabetes, we have to take special precautions. Growth hormone deficient patients are often obese. They often have family histories of type 2 diabetes, and giving growth hormone, especially to those who are uncontrolled, can lead to a worsening of glucose tolerance and to the development of more severe type 2 diabetes. So it's important to work very hard before starting growth hormone to get the diabetes in good control, and then to make frequent adjustments as needed in patients getting growth hormone therapy. Again, for hospitalized, it's important to recognize that 70% of children who receive growth hormone therapy to enhance their growth will not be growth hormone deficient when they are retested as adults, especially those kids who had isolated growth hormone growth. And then several months later, at least 3 months later, they should undergo formal growth hormone stimulation testing to determine whether they are still growth hormone deficient. And again, the vast majority of them will not be and will not have to take growth hormone again. Those children who had multiple pituitary deficiencies, genetic syndromes, pituitary or brain tumors, or who had received radiation therapy will almost always remain growth hormone deficient. And in these children, we recommend that growth hormone therapy should not be discontinued, that they should continue to receive growth hormone therapy throughout their stay with the pediatricians and into adult life. We can see that those children who have multiple pituitary deficiencies, here 2 or 3, are much more likely to be growth hormone deficient when they are tested as adults. Okay. So what are some of the issues about giving growth hormone therapy? As I told you, growth hormone therapy is contraindicated in patients with active malignancies. The use of growth hormone in patients who have been cured of cancer still remains somewhat controversial. In children, we have a much more data concerning the effects of growth hormone. And we know that, I think with really robust data, that growth hormone therapy does not cause any new primary cancer. There is a risk in those patients who have had radiation to the brain to having subsequent neoplasms. These are mostly benign meningiomas. In the adults, there is no evidence that growth hormone therapy causes any cancers, although we don't have nearly as much data as we do for children. And we don't really have any data concerning recurrence of primary cancers or subsequent neoplasms. Nonetheless, I think that growth hormone therapy has generally been shown to be safe, and in patients who've had cancers treated as children, we feel comfortable in treating them with growth hormone as adults. If you go to the internet, you'll see lots and lots of ads for growth hormone as an ergonomic supplement, something that will make you very buff and very strong and a much better athlete. Most of these supplements are not growth hormone. They're usually arginine. Oral arginine does not increase growth hormone. These supplements are benign. The only danger is to your wallet when you buy them. It is against the law to prescribe growth hormone for sports. Nonetheless, growth hormone is a very common drug of abuse. It's been used in all of the Olympics. It's not very easy to tell whether people have been on growth hormone. And we expect that the Tokyo Olympics, which are now going to be in 2021, may find more athletes doping with growth hormone. The internet will also tell you that you can grow young with growth hormone, that it's a fountain of youth. And again, most of what they're selling there are growth hormone releasers that don't in fact release growth hormone. But does it make sense to think that growth hormone is the fountain of youth? We've done many studies in humans, and we've done many studies in organisms, and essentially in every organism, from yeast to rodents, if you have defects in the IGF-1 or growth hormone or insulin signaling pathways, a defect in these pathways lead to an enhanced lifespan. And as you can see in this graph here, these mice who have growth hormone releasing hormone deficiency live much, much longer than their litter mates. So from our research point of view, there's no reason to think that giving growth hormone will extend lifespan. And in fact, there may be some reasons to think that it won't. As we decrease growth hormone signaling, we tend to decrease insulin levels. Longer lifespan. This leads to the question of whether growth hormone replacement therapy should be a lifelong treatment. And I think we don't have an answer to that, but at present I treat patients at all ages if they have growth hormone deficiency. The future is a long-acting growth hormone. There have been many, many long-acting growth hormone products that have been tested. Ideally, we can get away from daily growth hormone injections by getting weekly or maybe even bi-weekly injections of a long-acting product that would be just as effective as daily growth hormone therapy and just as safe and not have any new side effects. And also, most importantly, that it won't cost any more. And I think within the next year, you'll find that there will probably be 1 or 2 products available for the treatment of both children and adults in the United States with growth hormone deficiency. So this will be the newest drug in our armamentarium for treating growth hormone deficiency in adults. So let me leave you with these lessons. Adult growth hormone deficiency is a bona fide syndrome with distinct clinical features. And growth hormone replacement therapy can ameliorate many of the signs and symptoms of the adult growth hormone deficiency syndrome. Unfortunately, making the diagnosis of adult growth hormone deficiency can be complex and somewhat difficult. And it's for this reason that probably fewer than 10% of all adult growth hormone deficient patients are not, only 10% are being treated. The vast majority are not being treated because I believe the physicians either don't believe that growth hormone is efficacious, and I hope I've convinced you otherwise, and because of the difficulty in making the diagnosis. It's important to remember that growth hormone has numerous important hormone-hormone interactions, and that growth hormone should under no circumstances be used as an anti-aging tonic or a sports-enhancing drug. So I'd like to thank you for your attention, and I will stay around for any questions that you might have.
Thank you very much, Dr. Hoffman. The questions are being queued up here. I'm going to be looking at the QA in the chat here shortly. They've been treated with growth hormone and they've completed their growth, but many of them just tire from the injections at that point, and there's other factors. What types of things do you tell people in those situations to help, get them to be motivated to continue growth hormone?
Well, that's a very good question, and trying to keep patients on growth hormone can be very difficult. I think one of the important things is that when they are started on growth hormone therapy as young children, it's important to tell them that this may be a lifelong therapy, that it may have effects for them in addition to growing taller, that'll be beneficial to them throughout life. It's important, I think, as children do achieve their adult height and we decide to take them off for a brief period of time, to remind them that it is important at that point to do that. This is a job for the pediatricians and for the adult doctors. Some places have tried to get transition clinics. This has been very difficult, and nobody has a good solution to this. Our own solution at Stanford has been to hire a wonderful endocrinologist who's trained both in pediatrics and adult medicine and endocrinology, who will see them in both clinics so that they may be in a new venue, in a new hospital, but at least they'll have the same physician. But we lose most of these patients at age 18. They don't want to see a doctor. They feel fine, perhaps. They've moved out of their house. They're working. They're at school. They've left town. They don't have insurance. And so it is difficult to do that. I think it's important right from the beginning, though, to try to encourage the idea that this may not be just a short-term therapy, but something they may need for a much longer period of time. Joel, you're muted.
Thank you. We can't go on without some little glitches. So there's a question, can you comment on the specific example of an improvement in cognitive function in a patient or in a group of patients in general? And then the follow-up on that is, how long until you see any type of change, such as that would give you a sense that there's benefit?
I can't give you data from a controlled trial to show improvement in cognition per se. There have been improvements that have been seen on functional MRI studies. Some of the quality of life indicators suggest that there is an improvement, but that's something we'd still like to study more. The problem is that you need to do a controlled trial with that, and there aren't very many of those that will go on long enough and will be able to do testing that's detailed enough to actually be able to do that.
Okay. What about, is there an absolute or relative contraindication to treating an adult who has a non-functional pituitary microadenoma and also has concurrent, presumably proven growth hormone deficiency?
No, I mean, we treat many, many patients who have pituitary tumors that have not been operated on, that are still there. There's no evidence that growth hormone will cause any pituitary tumor to grow. Microadenomas rarely grow, 5% maybe, under any circumstances, and there's no data to even suggest that growth hormone enhances that growth. So that I would say a large fraction of the patients that I treat have, almost all of them have pituitary tumors, and many of them have either been operated on and still have remnants, or have never been operated on. So there's no contraindication at all.
A follow-up question to that, do you image these individuals serially just to verify that there's no change in the size of lesions in the pituitary?
In regard to doing multiple MRIs in patients with pituitary tumors, whether they're on growth hormone or not does not change whether I keep getting MRIs or not. And this is somewhat controversial. There really is no consensus as to how often to get an MRI once you've made the diagnosis. Some of the neuroradiologists published a position paper in the American Journal of Radiology a couple of years ago suggesting that since microadenomas rarely grow, that if a tumor is incidentally found and it's less than 5 millimeters, that you don't need to repeat that. I usually will repeat it at least once to make sure it's not growing, but with the understanding that they rarely grow and it may not be necessary in all cases.
Let's see. There's a question, how do you adjust growth hormone therapy according to IGF-1? I guess the individual is wondering, do you have a specific target standard deviation score, such as in pediatric endocrine care, we try to achieve a therapy that's slightly above 0 SDs for the IGF-Z score?
I think that the recommendation that we made in the recent guidelines that were published in endocrine practice say to keep the IGF-1 level between -1 and +1 standard deviations. And in general, I try to keep them above 0 and less than 2. And sometimes it's not that easy. Patients may not be giving themselves injections every day at the same time, so depending on when you get your blood test. But as long as it's not above 2 and is in the normal range, and they're feeling better over time, then I'm happy to do that. Well, usually it takes between 2 to 6 months to get them at the proper dose, and then that dose often doesn't change, for many years. And once you've got them on a good dose, I usually only check them once a year.
Okay. There's a question about concerns regarding radiation exposure. So obviously cranial radiation, such as, in those with, childhood like brain tumors is a risk factor for hypopit and for growth hormone deficiency. But what about, this individual asks, just radiation exposure, say with head CTs, particularly if there are multiple ones that are done? Is there any information regarding routine radiation exposure that you're aware of?
Well, I'm not aware of it, but the pituitary is relatively radio resistant. So I'm following a large number of patients who've gotten radiation therapy that encompasses the pituitary gland, very high dose for head and neck tumors, for example. And they will develop hypopituitarism in a minority of cases. And it may take decades for that to happen. I would think with CT scans, especially with modern CTs, that we're not talking about enough radiation to cause pituitary deficiencies.
Okay, thank you. I have a question that's coming from a parent. This is a parent who has a child that's being treated for childhood onset growth hormone deficiency. And the question is, once their child reaches basically, I would assume, final adult height, how do they go about approaching the discussion with their endocrinologist about extending growth hormone on into adulthood?
Well, hopefully their endocrinologist will bring the topic up to them. But if their endocrinologist does, and you want to be able to maximize the benefit of growth hormone to continue, is that, again, bone maturation is going to be going on for another decade. Brain development will be going on for almost another decade. So you want to be able to do that. And the pediatric endocrinologist should be able to either do the stimulation test herself or to refer you to an adult endocrinologist who will do that. We sometimes have little tussles between the pediatricians and adult endocrinologists as to who's going to do the
Never happens.
But you can usually find somebody who will do it. Unfortunately, the testing is kind of a big deal because, at least at our institution, even if we do the masomorolin, which is an oral preparation and just requires 3 or 4 blood draws, they make us do that in our infusion center. We can't do it in the clinic itself. And as a result, that's quite expensive, and we have to get prior approval to do any of those kinds of tests.
Okay. This is actually a very good question, and something I'm very interested in your answer to. If you have an individual who does have a traumatic brain injury, what would be the optimal timing you would suggest for assessing for growth hormone deficiency in that person, either by IGF-1 measurement or by doing actual stimulation testing?
That's an excellent question. There's been some suggestion that some of the pituitary deficiencies that are seen acutely in these patients will essentially become ameliorated by themselves over a period of time. So there are some people who say we should test them early. You can get an IGF-1 level after a couple of months because it takes time for IGF-1 levels to fall. They have a very long half-life. And if it's low, then you can do testing and treat them early, because that may help with the healing process. There's no data to prove that, but that's a suggestion. Others will say, well, this is just part of the body's way to compensate for injury, and we should wait a year to see whether these are permanent. So I don't think there's an answer yet, and I think that we still have a lot to learn. But in general, in my practice, most of the patients that I see with traumatic brain injury have had it in the past. It's been a year or more, and that's when I test them. So I think the acute early phase is still somewhat experimental. Having said that about traumatic brain injury, I defy you to find somebody who's never had some sort of a minor concussion in their lives. And you have to try to determine whether the brain injury that the patient is complaining of was really something that may have been significant and had sequelae later on, or was just something that all of us ultimately will develop during our lives.
Okay, thank you. There's a question about if you have a family history of colon cancer, since colon polyps are reported increased in acromegaly. Does that play any role in concerns on your part as far as growth hormone treatment in a patient?
Well, I think if you do have a family history or a personal history of having colonic polyps, it's important to have regular follow-ups, either with colonoscopy or other tests to look for colon cancer, but I don't think that is a contraindication itself. It is true that patients with acromegaly have an increased incidence of colonic polyps and possibly an increased incidence of colon cancer. That continues to be somewhat debatable. But again, when we're giving growth hormone replacement therapy, we're trying to do this in a very physiologic way so that the IGF-1 levels are in the normal range and not in the high range as in acromegaly. And if we're doing that, there's no reason to think that physiologic levels of IGF-1 are likely to cause colon cancer, in my opinion. So I think you should have the normal screening that you would have anyway. And if there's a family history of colon cancer, more frequent screening, and you may decide that you don't want to take any other risks in that case. But I don't consider it to be a contraindication.
Okay. And there's several questions about growth hormone stimulation testing agents. I mean, you had mentioned the various agents, and you had mentioned that many of them are no longer considered recommended. Is there anything that you would expand upon on that statement?
Well, I think that it's quite clear that insulin tolerance test and the glucagon test have been around for quite a while. And while we don't understand why the glucagon test works, it's been tested in enough people that I think it's a good test. The massamorelin test, I think, is also quite good, although we don't have nearly as much experience with it in all cases. But all the data so far looks fine with that. And it has the advantage of fewer blood draws and not having to have an injection. It's safe. Although you have to, it will increase the QT interval. So if you want to make the diagnosis of growth hormone deficiency, you can use an ineffective agent, but I don't think it makes sense to do that. And I don't think the insurance companies will look fondly upon you using something that really isn't proven. And we used these things in the past. It came from its use in children, and I'm not a pediatrician. I don't want to speak to it, but I think that even in children, many of these tests are not good. Giving an IV infusion of arginine may work in some cases. Arginine will inhibit somatostatin release and may cause GHRH, but if you have hypothalamic disease. Anyway, I think those are the three agents that are uniformly recognized, and all of the guidelines from ACE and from the Endocrine Society recognize no others.
Okay. I've been notified that we have time, or we're going to do one more question, and then I'd like to open up if you have anything else that you would like to add. But the last question is from someone who's interested in receiving care. So is there a list or some type of resource for families or for patients that list, adult endocrinologists throughout the country or even throughout the world who do particularly treat adult growth hormone deficiency or have an interest in it?
That is a very good question, and it's one that I don't know the answer to.
Okay.
So most academic medical centers will have somebody who's interested in neuroendocrinology and will do the test, but not all.
Well, thank you very much. This has been very, very informative, and I wish that I had time to address or have you address all the questions that have been asked, but in summary, is there anything else that you would like to share with the audience before we close up the webinar?
Again, I'd like to just emphasize that growth hormone has been studied more than any other hormone for pituitary disease. There are no controlled studies showing the benefit of thyroid hormone replacement in secondary hypothyroidism or glucocorticoid replacement in secondary adrenal insufficiency. Not that I'm suggesting that we do it, but there is really a very robust set of data suggesting that growth hormone deficiency has a number of sequelae and that growth hormone therapy is safe and effective for people with the treatment. and that it's imperative when we're treating our hypopituitary patients that we offer them the opportunity to get growth hormone, and that simply isn't being done now. And I want to encourage all the endocrinologists to learn how to make the diagnosis and how to treat, or to find a colleague who will do that for them. So thank you very much for your attention, and I've enjoyed meeting all of you by Zoom. Take care.
Well, thank you again, Dr. Hoffman, and thank everyone that took time out of their schedule to be part of this webinar.